to introduce Dr. Shay Menascu, who is a pediatric neurologist, and he works in the MS Center here with us in Sheba, taking care of many patients with pediatric MS. There is always a question, what is pediatric multiple sclerosis? Is it till the age of 21, like we define in the US? But I see some pediatricians saying no, of course, and also not 18, but actually real pediatric MS is till the age of 12. Anyway, Shay is a dedicated pediatrician, but today he will speak about an adult project. So he's growing up with us, looking at the cognitive aspects of RIS, radiologically isolated syndrome. Please, Shay. Thank you.
Good morning, and thank you very much for the organizing committee for inviting me here. And it's a great pleasure, especially celebrating the 20th anniversary, in which I just joined. And you just heard from Professor Helma, I'm a relatively strange bird to the Institute, as I'm a pediatric neurologist among you guys, which are all, I guess, or the majority are adult neurologists. So I'll try to do my best and just showing you something which it's very important and also have facts in pediatrics. And what is actually radiological isolated syndrome? And Akuda back at 2009 was the first one reporting some similarity about completely asymptomatic brain lesions showing hyperintensity similar to MS involving the white matter lesion load, atrophy, spinal cord lesion, cortical lesion, and different changes in the metabolites. And as you can see right now, this is a Akuda criteria, taking consideration that one of the important facts are 2T hyperintensity lesions fulfilling the Barkov criteria for disseminating in time and space. And obviously, as you can see right now here, that there is no signs of any other evidence or any other sickness of the CNS. And interesting enough, when you look back in the articles, you already find in 83 some interesting articles by Fakad and the best, looking on 12 cases of so-called asymptomatic demyelinating lesion which were found on brain autopsy. And when you look back on these 12 interesting cases, as you can see right now, 4 cases were reported to have no previous history of neurological illness at all. 4 had neurological illness, but MS was not even accountable. And the other 4, MS was accountable and neglected. And even 6 out of these 8 patients were relatively old to be diagnosed with MS, which maybe cause us to think that maybe this is completely other syndrome. So we might not even talking about RIS. Maybe we are talking about PIS, the pathological isolated syndrome, which was never reported before. RIS, PIS, and who knows what next. So looking back also on how frequent is abnormal MRI on healthy subjects. So in this interesting article, 16 cohort involving more than 15,000 patients was looked at what can be found as asymptomatic lesions. And you can see that only 9 cases were reported with a prevalence as low as 0.06. And Wesley and his colleagues in Karachi were looked also on this cohort of 864 persons in the age of 15 to 40. And interestingly enough, all of these persons underwent MRI, which were done, by the way, on their own expenses. And only 6 cases were found showing how low is the prevalence. And you might ask what happened to these persons. As I told you, all paid from their own pocket. They could not afford to do a second MRI, so we don't even know what happened to this population, although that it's relatively high reported of demyelinating lesion in such a warm country as Karachi, Pakistan. So their conclusion is that the range is very low and it's moving between 0.06 to 0.07. And when Okuda went back to his study and look on the 5 years prevalence of how fast they will move to the first clinical event, he looked on his cohort of 451 RIS patient with the mean age of 37 when they had the first MRI, with the mean clinical follow-up of 4.4 years. And surprise, he reported that the clinical event is going up to 34% of moving on in 5 years period to the first abnormal MRI. And even out of this 34%, even almost 10% fulfilling the criteria of primary progressive MS. And when you looked on their multivariant models, age, sex as male, which is not surprising, lesion in the cervical and thoracic spine were the one that actually identified significant predictor of developing the progression of the disease. And it's also interesting to know that it's not only a radiological syndrome, something is happening in the brain. And looking on 23 RIS patients that underwent magnetic spectroscopy, looking at the level of N-acetyl aspartate and choline, the ratio normalized to creatinine, both on the lesion area and not in the lesion area, and compared to 20 healthy subjects, and I will tell you that these healthy subjects were taken from the hospital staff, which you wonder who will want to participate. Maybe also his brain will be scanned and found to be RIS. But anyway, the levels were significantly lower in the RIS patient. And as we know that N-acetyl aspartate is synthesized exclusively in neurons, it considers a powerful marker of neuron integrity. So its decrease signified basically MS disease progression. So exactly was found the same thing in our RIS patient. So it's meaning that it's not such a symptomatic issue. It's causing actually axonal loss. And as we know that over the 10 or more, a lot of studies was published as in MS patient involving their actually cognitive decline early in the stage of the disease in different fields, as you can see in memory, attention, and so on. And the same was found actually in CIS patient. So you wonder what's going to happen now with our RIS patient. And a study done by Haikiki from Professor Amato group, which I just yesterday found how to explain her name, and I realized that she's from Algeria, right? Not from Japan, as I thought before. Okay, good. So she reported actually 4 asymptomatic patients, which found to be having hyperintense signal on their brain MRI and underwent cognitive testing. And you can see that regardless if the first case was reported 5 years doing cognitive testing before he was evaluated, or the other 3 cases, all of the things, all of these subjects were actually having problem with their memory testing and moderate function and attention and executive function, exactly like the one that you can find in MS. And that's despite any clinical involvement. And LeBron also looked on the study involving 26 patients occurring on the frequency and tried to look what's happening to their cognition. And you can see when comparing RIS patient, MS patient, and normal subject, no differences were found between the RIS and the MS. And when looked at the thing, nothing really important was found compared, obviously, between 2 groups. The normalized one was not really function. And when you look at what's the difference between the RIS and the MS, the only thing that was found, the differences in digital spam. Okay, so digital spam, but how many of you really know what is digital spamming? And we'll touch it a little bit later. But for me, like I told you, I'm a strange bird. I could not realize really what is the differences. So I really dipped in this article. And if you look, so 16 of the RIS patients, the majority, and 23 of the MS patients, which is again the majority, had at least 1 result under 2 standard deviation, as you can see right now. And 8 of them, of the RIS patient, and 19 of the MS patient had at least 2 results under standard deviation. And no significant difference were detected between the RIS and the MS concerning the main cognitive except of the executive function. And for me, like I told you, I had a problem. I had a problem because I could not realize exactly what is 1 or 2 standard deviation disease-wise, how severe it is. Give me a number, give me something that I can understand. Maybe just because I'm a simple pediatric neurologist and I'm not so sophisticated as you guys. So we really went back to look on our cohort, and we can identify 36 subjects that fulfill the Okuda criteria, 23 females and 30 males. The age was 33 years plus minus 2 years, and the range was, you can see, between 1 to 15 years, such a long follow-up years, and surprisingly, only 22% converted to MS in 4.2, so less patients over shorter period of time. And you can see the reason why they were scanned, and you can see that out from the 36 patients, only 24 patients were able to be followed up, and the headache was the majority of the cases why these persons were scanned initially. And also, unfortunately, 2 of our patients that became our patient was actually before our students and participated in a study and was diagnosed with RIS. And all of them underwent the global assessment battery, which we call NeuroTracks, and I'm not going to go deeper to details as I know that we're going to have very meticulous hands-on workshop just a little bit later. But it's a system that works with testing cognitive domain, including memory, executive function, visual, perceptual, attention, memory, and so on. And you'll have an example just a little bit later. And what's important in this system, again, maybe because I'm a simple pediatric neurologist, it gives me a number. It's giving me a number scoring the normalized to standard scale of about 100, which is a mean, based on the population age and education. You remember age and education, which is changeable between population in different areas, and matched to population, which is normal. And it's giving you a value. If you are 1 standard deviation, so you score less than 85. Again, number, not only 1 standard deviation, but a number, a value. And if you score below 70, you're already severely impaired and have cognitive impairment. So I mean, think that you can really work with numbers, not only with values as what is 1 standard deviation and 2. And again, why? Why it's so important, at least for me, as you can see this iceberg. It's meaning what we're going to discover. We're going to see only the tip of the iceberg, or we're going to discover the whole iceberg. And keep in mind that our lecture is talking about RIS, which is completely asymptomatic patients. And why it's so important? Because when you look on 1 standard deviation, it means that only 2.2% of the population going to be really collected and evaluated. But when you really define something as 2 standard deviation, you will have less patients than if you define 1 standard deviation. And again, the concept is how fast you want really to diagnose this patient, and we can talk about it a little bit later. Is it really early? So you will define what is a 1 standard deviation and maybe start to evaluate or treat them, or 2 standard deviation, which will be later, and again, giving them a numeric value, which is easier than to say 1 standard or 2 standard deviation. And you can see that when we tested these patients, the main thing that crossed our mind, that there is change in their information processing speed. And what is really information processing speed? We'll talk a little bit later. But you can see that compared to the rest of the testing, again, the NeuroTracks, which we will see later, information processing speed was the one that was really involved in their findings. And again, floating the same article, which was published before, but now Professor Amato putting the RIS patient in front of it, you can see directly the information processing speed is the one that was declining very fast compared to the other things. So this is a previous article, and this is our RIS patient, exactly putting it in front of the disease progression between CIS, RRMS, and SPMS, and maybe our PIS patient. So information processing speed, but what is information processing speed? So let's figure out that I'm going to give you a very complex, right now, mathematical problem. And if the answer for this very complex mathematical problem will be more than 5, you think that you have to click the right button. If it's 5 or lower, you have to click the left button. Are you ready? Okay, if you guys are ready, and you are smart because you are an adult neurologist. Okay, here we go. Okay. Very good. So how many of you clicked the right one? No cheating, no cheating. How many of you clicked the left one, please? No one really clicked it. Okay, so. Overall, the white matter hyperintensity volume reported to be linked more closely to the speed information as I showed you. And this is a very complex task. You think about it. You have to think, you have to calculate. By the way, the answer was 9, right? And then you have to think, calculate, think to click the right, think to click the left, and then do it. So for us, look how many processes we just activated. And keep in mind that our RIS patient, as I told you, losing their neurons. So it seems it's something that we have to concern. And there were many articles looking also on the decline of process speeding in also non-demanded elderly in different callosal and pericallosal lesion. And although there is clearly strong relationship between the regional of total white matter hyperintensity, we think, and we are in the process of evaluating it, that's frontal white matter hyperintensity were actually the one that affecting the speed processing and suggesting some regional specificity, meaning that involving the frontal region, the executive function region are the one that are important. And just to conclude, so I hope that I convince you that cognition is really impaired in RIS patient. And mainly information processing speed, as I showed you with our very complex task. And we need to argue, is it really further studies that really like to teach us that maybe some disease need to be treated even before you can call it disease? Maybe RIS patient need to be treated in involvement? And maybe also many peace patients are just wandering around and never came to our evaluating because they never had scans, because they never complain. And maybe the cognitive decline just being connected to age. Thank you very much.